Hello, my name is Kaylee Robinson. I will be presenting on an observation day patient case study that was performed at Midwestern University on October 15th of 25, and the patient will remain confidential throughout this presentation. Going into the patient's profile, the patient's age range was between 20 to 25 years old. Their ASA stage was stage 1. Their dental history and medical history that was reviewed, it was noted that for their medications, the patient was taking acetaminophen, 500 milligrams for neck pain due to a car accident that occurred at the end of September. And there was no chief complaint. However, the reason for their visit, they needed a medical history review, an EO-IO exam, assessments, radiographs, and a dental exam. For the patient's oral assessment summary, the key oral findings were an abnormal bilateral mandibular tori that was lobulated, and they had missing teeth of numbers 1, 16, 17, and 32. For their overall health status observation, generalized periodontal classification was shown that the patient had adult gingivitis, stage 1, grade A. For their caries risk, it was moderate, periodontal risk was low, cancer risk was low, and calculus detection was moderate. Bite wing images were prescribed for the patient at this appointment. The patient's last x-rays were full mouth x-rays that were given on June 26 of 2024. The patient was needing the updated bite wings for the examination of that appointment. The following slides will show the 2024 x-rays that will be used to evaluate the anatomy and restoration identifications. The technique that was used for the bite wing images during the appointment was the paralleling technique using the XCP receptor holder, beam alignment device, and the Nomad X-ray unit. The operator used the paralleling technique to better accommodate the abnormal bilateral mandibular tori that was lobulated, allowing for open contacts on the bite wing images. This slide is the patient's mounted full mouth x-rays that were taken on June of 2024 and will be used for the rest of this presentation. I will be going over the anatomy identifications using the 2024 full mouth x-rays. This image right here is the PA number 5, which is the maxillary left lateral incisor and canine periapical image. In here, we see that there is a periodontal ligament space, which appears as a thin radiolucent line around the root of the tooth. The lamina dura appears as a dense radiopec line that surrounds the root of the tooth. And the pulp chamber is part of the pulp cavity and appears radiolucent within the tooth. The incisive foramen appears as a small ovoid or round radiolucent area located between the roots of the maxillary central incisors. And then lastly, on the very bottom where the arrow is pointing, in between teeth 8 and 9, is the median palatal suture, which appears as a thin radiolucent line between the maxillary central incisors. This next X-ray image is the bite wing of number 10, which is the left premolar bite wing. And just following the arrows, starting with the DEJ, which is the dentin-enamel junction, appears as a line where the enamel, which is very radiopec, meets the dentin, which is less radiopec. Next is the enamel, which is right underneath it, the outermost radiopec layer of the crown of a tooth, and then the dentin, which appears radiopec and makes up the majority of the tooth structure. It is not as radiopec as the enamel. And then on the very bottom is the alveolar crest, which appears radiopec and is typically located 1.5 to 2 millimeters below the junction of the crown and the root surfaces. This next dental image is the bite wing image number 8, which is the right molar bite wing. And just following along with the red arrows as well, starting with the external oblique ridge, it appears as a dense radiopec band that extends downward from the ramus of the molar region. And then next is the impacted tooth, which is tooth number 32 on this image. It appears radiopec showing the third molar colliding into the second molar. This next image is the PA number 6, which is the maxillary left premolar periapical. And following along as well, starting at the top with the nasal cavity of where that's pointing, it appears as a radiolucent area superior to the maxillary incisors. And then right underneath, which is to the right of it, is the inverted Y, which appears as a radiopec upside down Y formed by the intersection of the lateral wall of the nasal fossa and the anterior border of the maxillary sinus. And then right next to it as well is the maxillary sinus. Appears as a radiolucent area located superior to the apices of the maxillary premolars and molars. And then right underneath it is the floor of the maxillary sinus, which appears as a radiopec line. This image is the PA number 15, which is the mandibular central incisors periapical. And right underneath, right in between teeth number 20, 24 and 25 is the mental fossa, which appears as a radiolucent area above the mental ridge. And then the mental ridge, which is right underneath it, appears as a thick radiopec band that extends from the mandibular premolar region to the incisor region. And then right underneath all of those is going to be the genial tubercles, and that appears as a ring-shaped radiopacity surrounding the lingual foramen. This image is the PA number 2, which is the maxillary right premolar periapical. And on this image, it shows the palatal root, which is sometimes can be hard to find. And in this one in particular, it appears as a radiopec. It appears radiopec and located posterior on the palatal side of the maxillary arch. It is most commonly found in the molar teeth. Using these same full mouth x-rays from 2024 on this patient, I'll be going over the restorations and caries identifications that I have found in these images. The ones labeled in red are going to be the caries and ones that will want to be identified and diagnosed by the dentist. And the ones in blue are the existing composite restorations that I have found on these images as well. So just going through these for tooth number 1, I found an unerupted impacted tooth mesially tilted. For tooth number 2, there is existing composite restoration on the occlusal surface, and that appearance varies from radiolucent to slightly radiopec. For tooth number 3, there's existing composite restoration on the mesial and occlusal surfaces, and there is cervical burnout on the mesial and distal surfaces of that tooth as well, which appears as a radiolucent artifact, which can be collar-shaped or wedge-shaped. There is also reoccurrent moderate interproximal caries on the mesial surface, which is decay that extends more than halfway through the enamel, but not into the DEJ. For tooth number 2, there is existing composite restoration on the mesial, occlusal, and distal surfaces, and there is reoccurrent moderate interproximal caries on the distal surface of that tooth as well. For tooth number 5, there is existing composite restoration on the occlusal surface, and there is severe interproximal caries on the mesial and distal surfaces as well. And that is going to show caries extending more than halfway through the thickness of the enamel. For tooth number 32, there is an unerupted impacted tooth, which is mesially tilted. And for tooth number 31, there's existing composite restoration on the occlusal and possibly on the buccal. So due to superimposition of the densities of a normal tooth, the buccal caries are difficult to detect on dental images and are best detected through clinical examination. So that's why I'm saying it could possibly have a buccal surface as well. And then for tooth number 30, there's existing amalgam on the distal surface, and that's going to appear completely radiopaque on a dental image. And when looking at the bottom bite wing, you'll see that on that distal side of that tooth, where I'm thinking it's amalgam, it is a lot more radiopaque compared to the other composite restorations, which are on the other teeth. And then there's also existing composite restoration on the distal and occlusal surface of that same tooth. Continuing with the identifications, for tooth number 16, there's an unerupted impacted tooth, which is also mesially tilted. And then for tooth number 15, I found existing composite restoration on the mesial and occlusal surfaces. For tooth number 14, there's existing composite restoration on the mesial occlusal, and there's also a cervical burnout on the distal side, which can be misidentified as caries. And then for tooth number 13, there's existing composite restoration on the mesial, occlusal, and distal surfaces. And for tooth number 12, there is also the existing composite restoration on those same surfaces, the mesial, occlusal, and distal. And then going down to the third molar of the mandibular arch, there is tooth number 17, which is a unerupted impacted tooth, which is mesially tilted. And then for tooth number 18, there's existing composite restoration on the occlusal and possibly on the buccal as well. So that will want to be clinically checked for that buccal surface. And then for tooth number 19, I believe that there is existing composite restoration on the mesial and occlusal, and it also seems that there is cervical burnout on that same tooth, and there is reoccurring interproximal moderate caries on the mesial side of that as well. For tooth number 7, there is incipient interproximal caries on the mesial and distal. And there is on tooth number 8, existing composite restoration on the mesial, distal, and possibly the lingual. The appearance on that one appearance varies from radiolucent to slightly radiopaque. And for tooth number 9, there's existing composite restoration on the mesial, distal, and possibly lingual. So that one will also want to be clinically checked as well. And then on that same tooth, there's recurrent incipient interproximal caries on the distal surface. For tooth number 10, there's existing composite restoration on the mesial surface and then moderate interproximal caries on the distal. Based off of the patient's restoration history, the patient has a high history of decay. It is highly seen in the interproximal posterior regions. And based off of the full mouth x-rays that I went over, the patient would be considered high risk for dental caries. And the bone health of the patient is normal due to the alveolar crest height, which is approximately 1.5 to 2 milliliters apical to the CEJ. As a dental hygiene student, I believe, and my conclusion and impression is that the dental hygienist of this patient should follow the dental hygiene process of care and plan goals with this patient and arrange next step visits for restoration treatment and diagnosing from their dentist as well.